The next speaker will be Dr. Aditya Bardia from Mass General Hospital Medical Cancer Center. He will speak on Trio US B12 Talent, neoadjuvant trastuzumab deruxtecan with or without anastrozole for HER2 low, hormone receptor positive early stage breast cancer. Dr. Bardia?
Thank you, Dr. Rim. Thank you, Dr. And the team for the invitation today. On behalf of the co-authors, it's my pleasure to present Trio US B12, the TALENT trial, an investigator-initiated clinical trial of neoadjuvant trastuzumab deruxtecan, T-DXd, with without anastrozole for HER2 low, hormone receptor positive early breast cancer. These are my disclosures. HER2 low breast cancer is an operational definition. It's defined by HER2 testing by a validated IHC assay and includes IHC 2+ and IHC 1+, IHC 2+ without a positive-ish testing, and IHC 1+. IHC 2+ refers to tumor cells that have staining in more than 10%, which can be weak or moderate, but it needs to be complete membrane staining. IHC 1+ refers to incomplete membrane staining in more than 10% of tumor cells. It should be noted that HER2 0 is not necessarily 0. There's some HER2 expression even in HER2 0. The reason there is interest in HER2 low subgroup is because it's potentially actionable. HER2 low is actionable because of antibody-drug conjugates. Antibody-drug conjugates with a bystander effect, like trastuzumab deruxtecan, have led to the development of this subgroup of HER2 low. Antibody-drug conjugates bind to an antigen like HER2, get internalized, releases payload, which causes apoptosis of the cancer cell. Newer ADCs, like trastuzumab deruxtecan, also have a bystander effect, so they can impact cells that do not express the antigen. So if there is HER2 heterogeneity, if there are some cells that express HER2 and others that don't, because of the bystander effect, these ADCs can impact all the cells. Trastuzumab deruxtecan has demonstrated impressive efficacy in metastatic HER2 low breast cancer. However, the efficacy in localized HER2 low breast cancer is not known. While neoadjuvant anthracycline taxane-based combination chemotherapy is often utilized to treat high-risk localized hormone receptor positive breast cancer, it can be associated with low pathological complete response rate, about 5 to 8%, which is slightly lower in HER2 low, a radiological response rate of about 50%, dose reductions, interruptions, and significant toxicity, including myelosuppression, peripheral neuropathy, cardiomyopathy, and risk of leukemia. We designed an investigator-initiated clinical trial to evaluate the efficacy of neoadjuvant T-DXd for patients with localized hormone receptor positive HER2 low breast cancer. Given the crosstalk between ER and HER2, we also evaluated whether the addition of endocrine therapy would improve efficacy of T-DXd in this setting. This is the design of the TALENT trial. Patients with hormone receptor positive HER2 low breast cancer who had stage 2 to stage 3 disease were randomized to receive T-DXd versus T-DXd plus anastrozole. Initially, patients were treated with 6 cycles of T-DXd, but after about half of the patients had been enrolled, there was an amendment to the protocol which increased the number of cycles to 8 cycles. After completion of treatment with T-DXd, patients had surgery, and then after surgery could receive additional adjuvant therapy as per the discretion of the treating provider. Tissue was collected at baseline before treatment with T-DXd, during treatment with T-DXd, and then finally at the time of surgery. The primary objective of the trial was to evaluate pathological complete response, residual cancer burden index. Secondary objective was objective response rate, tumor biomarkers, including change in HER2, and safety. Today, we'll review the results related to residual cancer burden, objective response rate, change in HER2, and safety. 58 patients were randomized 1-to-1 to these arms. There were no formal statistical comparison between the arms. Between September of 2020 to October of 2022, during the COVID pandemic, 58 patients were randomized to receive either T-DXd alone in Arm A or T-DXd plus anastrozole in Arm B. Majority of the patients completed the assigned cycles. There were only a few patients who could not complete 6 or 8 cycles of treatment. There was one patient who discontinued because of progressive disease. In terms of the baseline characteristics were well balanced between the two arms. Majority of patients enrolled in the trial had HER2 IHC expression of 1+. About 80% of patients in this clinical trial had HER2 1+ IHC expression. And about 50% of patients enrolled in this trial had lymph node positive disease. In terms of Ki-67 expression and tumor grade, about 1/3 of patients enrolled in this clinical trial had grade 3 disease. There were 4 patients who had HER2 IHC expression 1+ by local assessment, which was determined to be IHC 0 by central assessment, highlighting the analytical variability between labs. And we learned more about HER2 low and the various methods of determining HER2 low status in the next section by Dr. Rim. Now, looking at the results, starting with objective response rate with T-DXd based on imaging, this is a waterfall plot demonstrating the change in tumor size after treatment with T-DXd as compared to baseline utilizing RECIST version 1.1. Overall, the response rate in patients who received T-DXd as a single agent was 68%. There were 2 patients who had complete responses. In terms of T-DXd plus anastrozole, the response rate was 58%, and there were 2 patients who had complete response. We then looked at the HER2 IHC change from baseline to surgery with T-DXd, the HER2 IHC expression as per central review. We look at the HER2 IHC expression at baseline and then at the time of surgery after treatment with T-DXd. As you can see, for about half of the patients, there was a change in HER2 IHC expression after T-DXd treatment. Of the patients who had a change, majority had decrease in the HER2 IHC expression with T-DXd treatment. So change in the tumors from IHC 2+ to 1+ or IHC 1+ to IHC 0. And finally, in terms of the residual cancer burden after treatment with T-DXd, we looked at RCB 0, which is PCR, RCB 1, which is near PCR, and then RCB 2 and 3. There was one patient who had a complete pathological response, a patient who received 8 cycles of treatment with T-DXd, and the patient had baseline stage 3A disease. There were 2 patients who had RCB 1 with T-DXd treatment alone. 3 patients had RCB 1 as the best response after treatment with T-DXd plus anastrozole. It should be noted that the results related to the 6 cycles are final, but results related to the 8 cycles, this is an early look. The surgical outcomes are pending for 24% of patients who were treated with T-DXd alone and 31% of patients treated with T-DXd plus anastrozole. So we'll present the updated results next year. In terms of adverse events, the toxicity profile was consistent with what was seen previously with T-DXd. Nausea was the #1 side effect seen with T-DXd, both as a single agent as well as combination with anastrozole. The rate of myelosuppression, including neutropenia, was low. 5% of patients needed a dose reduction because of adverse event. There was one patient who had grade 2 pneumonitis. There were no cases of grade 3 or 4 pneumonitis and no cases of cardiomyopathy. There was one patient who unfortunately expired due to myocardial infarction. The patient also had severe GI toxicity, so possibly related to T-DXd. We also looked at the change in GI AEs over time. We looked at the incidence of T-DXd-related GI AEs in the first 20 patients, the next 20 patients, and then the final 18 patients. And as you can see, the incidence of GI AEs appeared to decrease over time as the study went on, possibly because of better supportive therapy. So in conclusions, neoadjuvant trastuzumab deruxtecan demonstrated preliminary evidence of clinical activity in HER2-low, hormone receptor-positive localized breast cancer with a toxicity profile consistent with previous reports. The objective response rate was 68% with T-DXd alone and 58% with T-DXd plus anastrozole. The rate of RCB01 was about 15% in both arms. The surgical outcomes are pending in 24% of patients in Arm A and 31% in Arm B, and updated results would be presented in the future. Nausea was the most common side effect seen with T-DXd. There was one patient with grade 2 pneumonitis, and the rate of dose reductions due to AEs was 5%. The addition of endocrine therapy to T-DXd did not appear to enhance efficacy, but caution needs to be exerted in deriving strong conclusions given the small numbers. Dynamic changes in HER2 tissue expression was noted after treatment with T-DXd. And the study provides a rich platform for additional translational research to evaluate more sensitive methods of HER2 detection, develop predictive biomarkers, and understand mechanisms of resistance in the residual disease, which could guide subsequent therapeutic strategies, including combination therapy. Overall, this is the first report of neoadjuvant T-DXd for patients with hormone receptor-positive HER2-low breast cancer and provides the groundwork for future studies with antibody-drug conjugates for patients with early-stage breast cancer. Would like to thank the study team, the team at MGH, UCLA, the TRIO US team, funding of T-DXd provided by Daiichi Sankyo AstraZeneca, and above all, thank you to the patients and their families for participating in this clinical trial. Thank you so much for your attention.
We're running a little late, so we have time for one question. Microphone number 3.
Nick Murray from Adelaide. You showed us that there were 2 patients who had progressive disease, and there were also, I think, 2 patients who went from IHC1 to IHC2. Were they the same patients?
Great question. So the question is about patients with progressive disease. There was actually one patient who had progressive disease. For that patient, the IHC did not change. There were 2 patients who had IHC change from 1+ to 2+, but both those patients had stable disease.